TAVR really began out of need because we had an aging population of patients who had severe aortic stenosis and were not candidates for surgery. And we had no other therapy. So we used a lot of the work that had been done with stents, a lot of the work that was done with balloon valvuloplasty, combined the two and created a new therapy that could address this urgent need in these elderly, frail, and difficult patients who had no other treatment alternatives. Our first TAVR was in June of 2005. It was really a primitive procedure using what we called an antegrade approach, extremely difficult, with high-profile devices, only a single valve size. We didn't have CT imaging to correctly understand the anatomy. The outcome was reasonable, but nothing close to what we currently achieve. So it truly was a primitive procedure with very early stage and rudimentary devices that have evolved extraordinarily over the past 10 or 15 years. We first felt that TAVR was truly going to be a therapy only as a niche for the sickest, highest risk patients. Then we began to understand that with improved technology, a simplified procedure, an extraordinary emphasis on the heart team, which is a multidisciplinary effort to correctly make decisions in these patients, and an avalanche of clinical trial data, that suddenly we had a therapy that was not only good as a niche for the highest risk patients, but had performed extremely well, in fact, as good as or even better than surgery in intermediate and even low risk patients. Well, there have been now 24 randomized trials that have been completed or ongoing in the field of TAVR, many of which compare the new therapy versus surgery, or to standard of care, or to other devices. And I think this series of randomized trials really has defined the field. I would point out that the partner trials, which began in 2007 and are still ongoing, have already published 7 manuscripts in the New England Journal of Medicine. And the self-expanding version of TAVR, which is the Evolute, have also contributed very importantly with multiple randomized trials showing very similar outcomes. I believe in the early days, we suggested that TAVR would be a good therapy in those patients who could not have surgery. Now we've completely turned that on its head. And we believe that if a patient has the correct clinical indications and has good anatomy where we can expect a good TAVR result, that should be the first therapy, or what you would call the default therapy versus surgery.